Paras.
Yeah, Dr. Namrata ma'am, please to
Okay.
open the session.
So welcome everybody to this yet another webinar from the desk of Cornea Society of India, and I'm sure it is going to be a great session. And I would request Paras to please take over from here and start the proceedings.
Thank you, ma'am, for being here. Good evening, everyone. I would like to invite you all for this, fourth session of season 2. And today we have a very interesting array of cases, which would, take you to almost the whole spectrum of HSV keratitis. For this particular session, we have esteemed panelists with us. This session is being conducted with one of the reputed institute from eastern region of India, that is Disha Eye Hospital, headed by Dr. Samar Basak, who is a director to Disha Eye Hospital, and he is one of the panelists. He is, accompanied by 2 other consultants from there, Dr. Tuhin Chaudhary, who is a senior consultant cornea surgeon, and Dr. Aditya Bajaj from Disha Eye Hospital. Along with them, we have Dr. Radhika Natarajan from Shankanetralaya. She is a deputy director and head of the Department of Teaching and Training. We have Dr. Revati Rajaram from Arvind Eye Hospital, a medical consultant and of cornea department from Coimbatore. And we have a microbiologist with us. That is a very unique feature for today's seminar, Dr. Joita Joseph from LVPI. She is the head of microbiology services at LVPI network. I welcome you all, and I welcome all our CSI executive members for being panelists today. With this, I would also like to introduce our young moderator with us today, Dr. Soham Basak, who is a consultant at Disha Eye Hospital, and Soham has done all the groundwork for this very interesting session. So Soham, I just hand it over to you, and you can start the session now.
Thank you, madam, for the kind introduction. So welcome everyone, esteemed panelists and dear speakers to this session of Kera Grand Round. So today we'll be talking about something you see in the clinics very frequently, often misdiagnosed, often underdiagnosed, and also sometimes overtreated. So we are talking about herpes simplex virus, and it's the various presentations of this entity that makes it a great masquerade. It can present as nummular keratitis, as bacterial or fungal keratitis, as endotheliitis, as uveitis. So diagnosing it and treating it correctly and rationally becomes quite challenging. So we have a very interesting set of 6 cases with us today, and we'll see how the various presentations are and how to diagnose them and how to treat them without compromising the safety of the patient. And our first presenter is Dr. Nibedita Das. She will be talking about bilateral herpes epitheliopathy.
Good evening. I'm presenting a case of bilateral herpes simplex keratitis in an immunocompetent individual. A 35-year-old male, a construction worker, presented with history of dimness of vision, redness, watering in both eyes since 3 weeks. He was on topical moxifloxacin, natomycin eye drops prescribed elsewhere. He had past history of similar and recurrent episodes since 3 years, which used to occur only in one eye at a time with few months interval. On examination, his distant best corrected visual acuity in right eye was 618 and in left eye was 624. Slit lamp showed bilateral atypical dendritic ulcer, mostly epithelial lesion with tapering ends. There were some focal areas of deep stomach invasion, but no stromal edema present. In right eye, the ulcer was close to pupillary area and there was old scar temporally. In left eye, the lesion was extended from 2 to 8 o'clock hours along limbus. There was circumciliary congestion without any KPs and AC reaction. Scraping from the dense infiltrate stain with gram stain showed gram-positive cocci. Because of atypicality of the lesion, RT-PCR of scraping materials was done for confirmation, which revealed HSV1 DNA. So final diagnosis was bilateral simultaneous HSVK with secondary infiltrate. Regarding medical history, there was no history of diabetes, asthma, atopy, skin disease or any medication. Systemic investigations were done for blood sugar, full blood count, CD4 lymphocyte count and serology profile, all were within normal limit. He was started on topical acyclovir 3% ointment 5 times a day, oral acyclovir 400 mg 5 times a day for 1 week, then 2 times to continue. Along with that, moxifloxacin drop continued 6 times and homatropin drop 2 times a day. After 7 days, the ulcers were healed, with scars in both eye, congestion were reduced and both eyes had improved visual acuity. On subsequent follow-up, he was on oral acyclovir 400 mg twice a day up to 6 months, and for the next 6 months, with only on topical lubricant, with no oral antiviral drugs. He continued follow-up for 4 years now, without any recurrence. I am concluding my case with following queries. What will be the approach in investigations and management in bilateral HSV keratitis, and how long should we continue systemic therapy? Thank you.
Thank you, Dr. Nivedita. And we have a very similar paired case. So from Dr. Mona Bhargav from Shankar Nethralaya, Calcutta. And we'll be looking at a case of bilateral archipelago keratitis.
Very good evening to everyone. I would like to thank Kera Grand Round team and Dr. Paras for this opportunity. My case being titled as Group of Islands with Snow. A 28 years old male presented with history of recurrent episodes of redness, pain and watering in both the eyes. There was no significant positive history except for intake of multiple courses of oral steroids. On ocular examination, there were multiple macular grade opacities arranged centripetally in a radial manner from periphery towards the center with intervening clear spaces in between. His routine blood test, immune status, quantiferon TB gold and collagen workup were all negative. A week later, he presented with the area of scleral thinning with pus point and subepithelial infiltration. Corneal and scleral scrapings, including HSV PCR, were negative. A month later, he presented with the area of corneal perforation with uveal show with Siegel's positivity. Tenon's patch graft with cyanoacrylate glue and bandage contact lens application were performed. At 6 months follow-up, Tenon patch graft was well integrated and there were no recurrences. Archipelago keratitis is an atypical form of herpes simplex viral keratitis with migration of limbal epithelial cells or radial arrangement of nerve fibers could account for this classical pattern of centripetal arrangement. The DDs are staphylococcal marginal keratitis, Thixon's keratitis, and ocular rosacea. Multiple recurrences, response to oral antiviral and steroid therapy, centripetal nature of arrangement account for viral etiology, whereas bilaterality, PCR negativity, recurrence on discontinuing steroids account for immunity. To conclude, PCR negativity can be due to inadequate samples, immune phase of the disease, or prior usage of oral antiviral therapy. So, precedence of clinical judgment in cases where clinical and microbiological evidence are not concurrent. Thank you.
So again, now we have seen two different presentations of bilateral herpes keratitis. Now I would invite all the panelists for their opinions. So we have some questions prepared. So my question is to Dr. Aditya Bajaj. So if you're seeing dendrite for the first time, how would you manage it? One, if it is unilateral, and two, like we saw in this first case, if it's bilateral, would your management differ? And how would you go about it?
So for a first time dendritic ulcer in a unilateral, if it's a unilateral presentation, I would simply go for a topical antiviral agent like acyclovir, ointment 5 times a day for 2 weeks, as well as a prophylactic antibiotic 4 times daily. And if it is a bilateral presentation, along with any history of any immunosuppressives use or any immunocompromise, or like diseases like atopic conjunctivitis or any skin disease, then along with the topical antiviral, I would definitely add oral antiviral. But topical steroid, no, only for epithelial lesion. I would not prefer a topical steroid along with antiviral.
Any of
Can we invite comments from others as well?
Yes, please.
Dr. Aditya, if the same bilateral presentation, as in this case in a immunocompetent person, then again will you start oral, or that is if it is immunocompromised,
I would
it's
start
different.
oral.
Yes.
I would start oral in this, even if it's immunocompetent, because we
Yes.
don't know, we cannot check for all the diseases, all the
Yes.
underlying diseases. So I would definitely start oral in bilateral case.
Yeah. And what oral, would you prefer oral acyclovir or valcyclovir?
Initially, I would go with oral acyclovir, and initially in a therapeutic dose for 10 days, 5 times, 400 mg 5 times, followed by twice daily, and then check for recurrences. So at any dose where there is a recurrence, so suppose a patient is quiet at a dose of 400 mg twice daily, and if he's compliant and he has a recurrence, then I would mark it like as a breakthrough dose. That particular dose of prophylaxis, he's having a recurrence. So then I would mark it as a breakthrough dose for that particular case. And then again, I would start the therapeutic dose of oral antiviral as well as topical antiviral. And then in the next, once I start the prophylaxis for him, I would go to a higher dose of prophylaxis.
What precautions will you take? Like any blood investigations, liver function, renal function?
I always ask for a blood urea serum creatinine and a random blood sugar before starting orals. That's a baseline. I start the oral acyclovir, but at the same time I ask for a baseline urea creatinine. But if for any reason if I'm starting oral valacyclovir, then I would also ask for a liver function test.
How many of you from the panel prefer valacyclovir over acyclovir, or which indications you would like to switch over to valacyclovir?
Generally, I prefer valcyclovir for the reason because bioavailability is better. The dosage will be easier for the patient to follow. So 5 times a day, many times, the compliance part may be little difficult to confirm. So twice or thrice a day and then going to single dose will be easier for the patient. And economically also not much of a big difference. The patient can afford, I would prefer valcyclovir.
Yes.
But as he said, the liver function is also important here in addition to renal function, and we have to keep a close eye on that.
And what would be your first line of management for epithelial topical management, like acyclovir ointment or ganciclovir?
I
Acyclovir.
would acyclovir.
Dr. Mamta wanted to say something. Yes, ma'am,
Goes
please.
without any consensus that most of the people prefer to use acyclovir.
Exactly.
Yeah, no, I would just agree with Dr. Revti, what she says. Like, I've stopped using acyclovir for longer times. One, it is like more biologically available. It's like the bioavailability is more. And the other thing is it's more user-friendly. Patient is happy taking just 2. Like, given a choice, if I have to take 5 tablets during the day, it's like quite, and especially when we want it a long term. So I think there are enough reasons that we can switch to valacyclovir. And I also want to add that I also have started using Gancigel on when we are on the maintenance dose, because it's not epitheliotoxic. So that also helps in reducing the recurrences. That's just an observation that I use. If I see that patient is not happy taking the tablets after a few months, then I just continue Gancigel 3 times a day along with the topical 1-drop steroids for all these patients. And if then we have a breakthrough recurrence, then I start again the oral. But after a few months, I switch to topical Gancigel, which is equally effective as of now.
How long would you continue this, madam? The topical Gancigel and the one-time daily steroid?
Forever.
Okay.
All these patients. I think what I have observed, if it's only an epithelial lesion dendrite, I'm not really seeing too frequent recurrences. But if I'm a stromal patient, then forever. I tell the patient this is like an easy thing. Gancigel 3 times and 1-drop steroids with some lubricant. And I'm not seeing any trouble on the epithelial level at all with this medicine. So
and
that's
bilateral cases. Somehow the bilateral cases recur.
Yes.
Then unilateral dendrites, no? It's very rare to recur often. But bilateral cases, as Aditya pointed out, once you taper, you can see recurrence, especially in children also.
Yes, yes. I
Um,
think children need very close watch when we deal with herpes. And the other thing I wanted to add, one of the first case that we should also take a history of topical steroids because most of the time their patient has referred. So it's the local immunosuppression basically, which is the reason for a dendrite flopping up. Like even in post-op cataract patients, I have a couple where because we give this topical steroids after cataract. So there are patients who come up with the dendrite even in the post-surgery patients. So it's very important to take the history of a topical steroid in these patients where we see these bilateral dendrites. So we should educate them not to abuse steroids in any form.
Ma'am, one thing that in which cases, in unilateral cases also you can start this oral acyclovir.
For epithelial alone, dendritic lesion, uniocular, generally, I don't prefer to start oral unless we establish, like, no, often it is recurring. Otherwise, I don't go for.
I usually feel to give the patients, those who are not so much compliant, first thing, and especially in children, sometimes it is very difficult for them to apply those ointments. In those cases, I usually give this oral also. In children and those who are not compliant so much. Otherwise, I also don't put it oral.
Another thing I am curious about, I want to know about the other panel members' experience, what they call as footprint. In many of these cases, you can see the dendritic lesion, but there is a subepithelial case. So would you like to treat it with the steroid or will it be effective? Generally, logically, like I don't think steroid has any role here, but if it is especially in the visual axis, like in this, the first presentation, one eye, it is almost in the visual axis. And such cases, would you like to start? I have never started, but I would like to know.
I use it actually. If I see that there is a subepithelial haze or a stromal lesion, it's anterior stromal, I use topical steroids because what we are seeing is not the active infection. It is the immune reaction to the bug which is there in the cornea. And steroids are the best agent. So I usually give all the patients when I'm seeing once the dendrite is gone and I'm seeing anything in the stroma, be it anterior stromal, I treat them with steroids. I may be a little hesitant to give a stronger one. I may initially start with a lotipred and see, and they do disappear. So I usually treat them with steroids with a cover of antivirals.
Before we move on to other questions, Dr. Mona, would you like to comment about your case? That was a very interesting observation and any specific thing which you would like to share with us?
Yeah, actually, I would like to ask Dr. Jovita regarding the role of acyclovir resistance. Is anything being done? Or the role of serology in this? Like I did PCR for two times, but both were negative. So is there any role of these two things in this? Like with acyclovir on also there were recurrences. So what do you think? Because you have an article where it says that a multiplex real-time PCR is superior as compared to IFA. So what do you think? Like what should I would have done extra in this case to get the actual positive PCR or something else?
Yeah, so real-time PCR is definitely more sensitive than the regular conventional PCR. But I just wanted to correct a statement which you wrote in the slide that because of prior antiviral therapy, you said that the viral DNA was not detected, but that's not true. If it is present, it will be detected even by PCR. A virus doesn't have to be viable to be detected by PCR. So it was probably either it was present in low load to be not sensitive enough to be detected by PCR, or it wasn't there at all. So real-time PCR is just more sensitive, but it would detect even if prior antiviral therapy was given. Regarding serology, we really don't do it over here because serology would not play a role in keratitis per se.
Okay.
So can I add some points?
We have seen that in a few of the articles which state that even in tears of these patients, like Fukuda and et al., one article is there which says from the tears of these patients also a high amount of detection is like 88% or something like that has been seen in epithelial scrapings.
Yes.
And even in stromal keratitis also. So what do you think, how much is the detection rate from PCR in these patients? Do you think that tears will be more useful versus the corneal scrapings in epithelial keratitis? versus a AC tap when there is a stromal or endothelitis? What do you think would give the highest number of viral load in these cases?
Mona, before she answers, can I add a clinical
Yes.
perspective, Dr. Jovita, so that you can factor that in together while answering? It's a question I've brought up with you also multiple times, that we know that HSV is a disease for life. Once a patient contracts the infection, it is there stashed away in the ganglion somewhere, and the virus keeps getting constantly shed in the tears or the ocular surface. Let's take a scenario where somebody didn't get a recurrence at all, or the HSV did not even manifest as a clinical disease. And there have been articles which show that in those people, if you take from the tears or the ocular surface, there's a high chance that you will come up with PCR positivity for HSV antigen. So coincidentally, when we get PCR positive in a clinically active disease, we are putting 1 to 1, 2 and thinking that this is HSV. So either the clinical context has to be very strong. If it is very strong, first of all, we are not going to do the scraping for PCR at all. Secondly, if the clinical context is weak and we are in doubt about the diagnosis, I definitely feel that quantitation of the PCR is a must before we jump into the diagnosis. The mere citing of the HSV antigen itself does not denote its etiology for clinical disease. But that said, the way I understand PCR quantification is done as so many copies per cubic milliliter or something when you give it from fluidic samples. This being a corneal scrape, how do we know what copy numbers are effective and what copy numbers do not denote disease?
So corneal scraping also would be diluted in PBS, and then when you extract the DNA, ultimately you're getting, it's the same thing. Whether you do it from an aqueous or whether you do it from a corneal scraping, you extract the DNA and dissolve it in the fluid. So you're finally getting it per ml only, you can quantitate it. So that way, that quantitation does not differ irrespective of which sample it is. But yes, as you rightly pointed out, viral load will give a clue as to whether it is an active disease or not, because there could be shedding in the tears. So tears would not be completely diagnostic because of the shedding. So yes, you have to take the clinical scenario, and a real-time PCR would help in such cases, because we have seen that the patients with active disease have copies of more than 1,000 to 10^6, whereas the ones in the controls which just had shedding, probably in the tears, had about below 50 to 100 copy numbers.
So in tear samples,
sorry,
can I interrupt for a while? So in tear samples, if the copy number is low, probably we are not dealing with active disease, it seems. Is it so?
I think you have to keep the clinical picture in mind before you come to that conclusion, but do not take only that.
Especially in dilemma cases when we are not very sure about, presence of viral infection. Yeah, ma'am.
Also regarding the acyclovir resistance that Mona was trying to bring up, like you all had discussed, I think a lot of the times it is because of non-compliance to acyclovir, because it's a multiple time a day dose. So before we brand them as resistant to acyclovir, I think we need to know that the patient is compliant, or switch to valacivir with a little spaced out dosage, so that we know that the patient is compliant. And one thing must be kept in mind: the true resistance, if it is there, switching to valcyclovir will not work, because both work against the virus in the same mechanism by inhibiting the thymidine kinase. So if this doesn't work, that is not going to work. So my question again tracks back to Jovita: if we can at all, if we suspect true resistance, then can we do susceptibility testing of the virus to either of these two antivirals?
So susceptibility testing is probably difficult, but yes, there will be genes which detect the resistance by molecular methods. So we can test, we haven't done that, but that is a good way forward to check for resistance if at all you all suspect that.
It would be a very sophisticated exercise, I think. No, it's very difficult and
no, it shouldn't be difficult. If we just get the gene, we can identify it by using that.
And I think there is no number or cutoff saying that when the disease is active and when it is inactive. And even in your article from your institute, it doesn't tells us the number of copies that this would be active state and this would be inactive state. So we are like not standing anywhere in number of copies. Even
we have arbitrarily set it at 50 to 60 based on the controls, and we put 2+2 standard deviations. But of course, we need many more studies from other regions also to exactly quantify that. So far, mine is still continuing to be the only study to say that cutoff.
Exactly. It was a very valuable starting point for us to understand the difference between viral shedding versus viral load in active load.
With this, Soham, shall we move on to the next two cases?
Yes,
yeah, because
so
we have 4 more to go.
Yes. So next we have Dr. Aditya Pradhan talking about deep herpes keratitis masquerade.
Good evening to all of you, and thank you Team CSI for this opportunity. So a 42-year-old female presented to my OPD with the chief complaints of diminution of vision, pain and redness in her right eye since the past 2 months. She was a diabetic and she had undergone some treatment prior, but there were no details available with the patient. The other eye was unremarkable. The affected eye was showing a mid to a posterior stromal circular infiltrate along with a very well circumscribed circular endoexudate with radiating DM folds. The section on the slit lamp shows some thinning at the central part of the lesion. The sensations were reduced, the presentation was atypical, and I was in a dilemma regarding to the etiology of the same. So the scraping was not attempted because of the thinning and the stromal lysis. She was started on empirical therapy with moxifloxacin, atropine, and oral vitamin C and doxycycline to counter the stromal lysis. And she was advised to undergo AC type for PCR so that I could be sure of the etiology. However, she was lost to follow up, and on the 17th day after the initial presentation, she underwent the AC type for PCR. This is almost 1 month after initial presentation. In the meanwhile, we got the report which was positive for HSV1, and we sent her an online prescription which consisted of a loading dose of oral valsiclovir, prednisolone, atropine, moxifloxacin, and CMC eye drops. And when she presented, there was a definite reduction in the intensity of the infiltrate. Some thinning was still present and few DM folds also, and the angry look was still there, but it was much better than before. We continued her on the same with a slow tapering of the steroids. So this was almost 3 months after the initial presentation, and you can see a scar has formed with the formation of a cataract. This is almost 6 months after the initial presentation, in which there is a well circumscribed scar which is just slightly off the visual axis. She was being planned to undergo cataract surgery, however, she was lost to follow up. So there is numerous literature both from India and from abroad showing the value of RT-PCR in the diagnosis of herpes simplex keratitis. There is also interesting case series from Japan in which they have shown 3 cases which at presentation mimicked fungal keratitis. However, PCR showed them to be of herpetic origin. And you can see on the right panel with appropriate antiviral therapy and corticosteroids, there was complete resolution of the same. Thank you so much for your patient listening.
And next we have again masquerade. So this is a co-infection of HSV and fungus. And the presenter is Dr. Charuta from LB Prasad.
Polymicrobial keratitis by Charuta Shrotriya. To begin with the history, a 38-year-old lady who was not a known case of any systemic illnesses reported to the OPD on 29 November 2021 with complaints of pain, watering, redness in the right eye since 2 months. There was no history of trauma or foreign body entry. She was using topical antibiotics, topical and oral antifungals, and topical cycloplegics and came to our hospital for further treatment when there was no improvement in the treatment given elsewhere. On examination, the vision in the right eye was counting fingers at 1 meter. The IOP was digitally normal. Eyelids were edematous. The conjunctiva was congested. In the cornea, there were mid-stromal multifocal pinpoint infiltrates involving the visual axis, measuring around 4.5 by 4.5 millimeters, with surrounding edema. Pigments and capes were seen on the endothelium, and scarring was seen in the periphery. The anterior chamber was well formed, and a 1 millimeter hypopyon was noted. The fundus was not visible, but the B scan was anechoic and the retina was attached. A scraping was taken, but no organisms were found. She was continued on topical antibiotics and the antifungals were stopped. Since there was no improvement, an endoscraping and an AC tap was taken for PCR, which turned out positive for fungal DNA and HSV. Antifungals were restarted along with a therapeutic dose of oral antivirals, and the patient was kept on close follow-up. The patient was responding slowly but surely, and the clinical picture had begun to improve with the scarring of the infiltrate and resolution of the hypopyon, and the patient was eventually shifted to a prophylactic dose of oral antiviral. After an interval of quiescence, the patient presented to the OPD 2 months later with pain, redness, and watering, and the clinical picture looked like this, with an epithelial defect, underlying deep stromal infiltrate, and central thinning. A scraping was taken which showed positivity of HSV in PCR while fungus was grown on culture. TA and BCL was applied and a therapeutic dose of ACV was restarted along with antifungals. Once again, there was a slow resolution of the infection, but eventually there was scarring, and this is the picture at the latest follow-up. The patient is on prophylactic dose of antivirals and is undergoing a contact lens trial for visual improvement. All the antifungals have been stopped as well. My questions for the panel would be, when to suspect secondary fungal infection in HSV keratitis? What is the significance of PCR positivity in mixed infections? And also, how to identify causative organisms in recurrences? Thank you.
Thank you, Dr. Charuta. So Dr. Kavya is here who managed the second patient. So I would like to invite her for her comments.
Yeah, thank you, Dr. Soham, Dr. Paras, for this opportunity, and Charuta, well presented. So just to quickly summarize this case, we had this patient who initially presented with a strong suspicion of fungal keratitis, but like Dr. Aditya also showed, there was a clinical suspicion of HSV as well. So although as per protocol, if we don't have microbiology positivity, we do not continue antifungals. So we had stopped antifungals because the initial corneal scraping was negative. And then we, because there was poor response, we decided to go ahead with an endoscraping and an AC tap. Surprisingly, we got PCR positivity for both fungal and HSV DNA, but we did not, unfortunately, could not send RT PCR at that point. So we just continued treatment on the lines of HSV and fungal keratitis. Now this patient responded very well. We had a period of quiescence and we continued her on twice daily dose of acyclovir and we stopped the antifungals. Surprisingly, when she came back to us 2 months later with a recurrence of the exact same clinical picture. So now the scraping again showed both positivity for fungus as well as HSV. HSV we expected, but fungus we did not expect that it would persist even after 2 months of stopping all medications. She was never put on topical steroids considering the coexistent infection. So the second scraping, now we got verticillum species and again the PCR was positive for HSV. And like Dr. Aditya mentioned earlier, because the breakthrough dose was BD earlier, we shifted her to a thrice daily dose of acyclovir. And with a TID dose of acyclovir and antifungals for a longer duration, now she has completely resolved and her last contact lens corrected visual acuity was 20/60. So this posed us some clinical challenges like what is the actual significance of dual PCR positivity in these kind of cases, and why would a fungal infection recur after 2 months without any other inciting factor, without any prior use of steroids, for example? Could the concomitant HSV infection have predisposed to some sort of local hypoimmunity status that could have led to recurrence of a fungal infection? So this was a patient that we thought would be fit for today's discussion, and I would like to invite comments from the rest of the panel as well.
That's a very interesting case and very difficult questions to answer, I think. So we would invite everyone in the panel for their comments about the co-infection part.
So what was the fungal species which was isolated? I missed that part.
Verticillum we got, Dr. Aditya.
Verticillum.
Yeah.
Sorry, I didn't hear it properly. What was the corneal sensation in this patient?
Corneal sensation, I'm not sure we documented, ma'am, but later in the beginning we didn't document, but later it was reduced because we had confirmed HSV and then we did again a complete examination. In the first visit, she was severely photophobic because it was more clinically towards fungal. So we did not check the sensations right at the beginning, but later on it was reduced.
Kavya, can I add my viewpoint?
Yes, yes.
Yeah, these cases are anybody's, there's no one right or one wrong. But there are one or two dictums by which I would operate. One is, as we discussed earlier in the last couple of cases itself, there is a possibility of HSV remaining passively shed whereas there is no zero possibility of fungus remaining passive on the ocular surface. So between the two, I would definitely take the fungus more seriously than the HSV. So either the HSV is incidental or it is a promoter. Fungus is definitely there. You do not get fungus from the ocular surface just like that as a commensal or as a shed organism. So that is the first premise. Second premise is that you err on the treatment or you delay the treatment, nothing is going to happen to HSV within a few days. Whereas you err on the treatment, fungus may worsen precipitously. So these are the two dictums by which I would operate. So I would pump on antifungals even if the clinical picture is not very concise and clear. And yes, even though the HSV may be contributing, because we detected PCR and because antivirals are not very toxic in renal competent patient, I would give them also. But the fungus would take precedence in my mind for the two reasons that I told.
Yes, ma'am. Thank you. So, Dr. Joeta, the question about the PCR positivity, the double PCR positivity. So this kind of stumped us. Second time, we should have sent a real-time PCR. I agree, that was a lapse. That would have actually helped us understand how significant the viral load is, like Radhika ma'am also mentioned. It was probably the fungus infection that was taking precedence. So your comments on that?
You've answered your question yourself, but I don't know why you even doubting that. Why do you think that both cannot come positive by PCR?
No, just like any experience in that, because we thought that
we do see actually quite a bit of cases. I think now Amrita is also writing up a case series where we have seen multiple times HSV with fungus, HSV with acanthamoeba. So it's not like it's not possible. It's definitely possible. But yes, your real-time PCR would have given you a better clue on the viral load, on whether it was responding or whether it is just a natural shedding or whether it's still an active infection. Second time, when you had the chance, maybe real-time PCR would have had the answer.
Yeah. Like sometimes we would be kind of, missing viral infection in presence of fungal secondary infection. Like, I mean, it would have been the other way around some of the times, unless we would have a positive PCR for both the things.
Does HSV cause any sort of local hypoimmune status? I mean, it's just a guess, but I'm not sure if that happens. Any possibility of that could predispose to such a protracted fungal infection?
I don't know. I don't know.
No, this case, fungal infection, I don't call it as a protracted one, because in between the treatment was aborted. And it's in fungus, it's well known. Even after 6 months, it can recur. So it recurred like that, probably. That is the way. And local anesthesia or hyposthesia of the cornea, that could be a predisposing factor for any suppurative infection. And fungus also in that case. And what about the systemic diabetic state and other things in this patient?
No, she was a young female, healthy otherwise. No
systemic illnesses. I had a question regarding this case, if I could ask. If the infection was primarily fungal, why did we see a resolution once we started the oral antivirals, once the PCR came positive? Also, secondly, would there be any connection to the recurrence of the disease once the patient was stepped down to a prophylactic dose? Because the antifungals were stopped much earlier, but the recurrence came much later. This, I feel, could point towards HSV being part of the infection as well.
Radhika, would you like to tell anything? It is quite possible that both coexisted also in active manner. It's quite possible. But fungus, if the treatment is not complete, anytime it can recur. That's the issue. So no harm in continuing that antifungal, even after you start the oral antiviral drugs. No harm, because once smear positive or culture positive fungus you saw, and always it's a pathognomonic. It's not just a incidental finding. We need not even suspect that.
Can we invite some comments from the CSI panel? Even we have Dr. Savitri on panel, ma'am. Savitri, ma'am, your comments on this? This was a very challenging case, it seems.
Yeah. I think there is no reason to suspect that fungus was incidental. It was there. It was proven. So you have to take into account. And I think all has already been said. So it was a mixed infection, definitely.
Thank you,
So-
everyone.
Yeah, thank you. Thank you for sharing such a nice case, Kavya.
Yes.
So can we move on to the last two cases and then maybe then we can take questions further?
Yes, ma'am. Yes, ma'am. So next we have the couple of cases on HSV and immune mechanism. So it's like HSV causing immune keratitis and immune ocular disease leading to HSV. So first we have a case presentation by Dr. Gayatri.
Good evening, I'm Dr. Gayatri from Chennai and I'll be presenting an interesting case of HSV keratitis. So a 41-year-old female who was HLA-B27 positive complained of pain, redness and photophobia in both eyes for 8 months. On investigating, her rheumatoid factor was negative, ANA, ANCA, CRP, ACE and syphilitic workup were negative and her chest x-ray was unremarkable. She was diagnosed elsewhere with bilateral immune-mediated diffuse anterior scleritis and was given topical and oral steroids. She was also started on oral tofacitinib, which is a JAK inhibitor, 5 milligrams twice a day for 1 month. When she presented to us, she had a visual acuity of 6/6 and 6 in both eyes. She had mild scleral congestion, a few white stromal corneal infiltrates with peripheral vascularization in both eyes. Her anterior chamber was quiet, lens was clear and fundus was unremarkable. Based on the clinical suspicion, she was diagnosed with bilateral herpetic stromal keratitis with scleritis and was given oral valacyclovir 1 gram BD, indomethacin SR 75 mg BD and eye drops prednisolone acetate 4 times a day in both eyes. At the 3 months follow-up, she resolved well with a picture of healed scleritis with a few peripheral stromal scars and a quiet eye. So we would like to present this case as we feel tofacitinib is a possible risk factor for developing herpetic keratitis. So tofacitinib is an inhibitor of enzymes Janus kinase 1 and Janus kinase 3, which interferes with the JAK-STAT signaling pathway and has recently been approved for use as an anti-rheumatic drug. The known adverse effects of this drug are cardiovascular events, venous thromboembolism and respiratory tract infection. 4 times a day in both eyes. At the 3 months follow-up, she resolved well with a picture of healed scleritis with a few peripheral stromal scars and a quiet eye. So we would like to present this case as we feel tofacitinib is a possible risk factor for developing herpetic keratitis. So tofacitinib is an inhibitor of enzymes Janus kinase 1 and Janus kinase 3, which interferes with the JAK-STAT signaling pathway and has recently been approved for use as an anti-rheumatic drug. The known adverse effects of this drug are cardiovascular events, venous thromboembolism and respiratory tract infections. This drug is notorious for causing herpes zoster virus reactivation as it inhibits the JAK1 and 3 and modulates the immune response via down regulation of several cytokines and thus increases the baseline risk of herpes zoster. Various cases of ocular varicella zoster, herpes simplex virus and cytomegalovirus retinitis have been reported. So we would like to highlight the importance of eliciting a drug history of tofacitinib in all patients diagnosed with herpetic keratitis. Thank you.
Thank you, Dr. Gayatri. And finally, we have our last presentation. It's a case series on PUK and HSV.
Good evening,
the presenter
everyone.
is Dr.
I'm
Manvi.
very thankful to Cornea Society of India for providing me with the opportunity. I'll be presenting a few cases where HSV was a masquerade for us. The first case was a 50-year-old male who presented with redness and watering since 1 month. There was no history of recurrence. There was a history of fleeting joint pains. The patient had a crescent-shaped peripheral corneal ulcer from 5 to 7 o'clock with a 4 into 2 mm area of iris tissue prolapse. The patient was treated with a tectonic patch graft and a lateral permanent tarsorrhaphy. The patient had seropositive rheumatoid arthritis and treatment was started for the same. But at 9 weeks, the patient developed an early graft melt with the appearance of dendrite at the host site, for which we started the treatment on oral and topical antivirals, along with amniotic membrane transplantation and a bandage contact lens. This patient gained a vision of 6/9 part post-cataract surgery done under the cover of oral antivirals. The second patient was a 77-year-old male with diminution of vision in the right eye since 3 months. This patient had a geographical ulcer with significant thinning and reduced sensations. We treated this patient on topical and oral antivirals with oral steroids and lateral permanent arthrophy. The defect healed with scarring. Similar fate was for another male who had a peripheral ulcer with history of redness and deep vascularization with a central adherent glaucoma. The management was on similar lines. The fourth case was a 50-year-old male with painful diminution of vision since 1 month associated with redness. The patient was a known case of HSV keratouveitis. There was a crescent-shaped peripheral ulcer with significant thinning and sloping edges. In view of the old nebulomacular scarring, our past experience, and the patient being a known case of HSV keratouveitis, we started this patient on full-dose oral and topical antivirals and did an amniotic membrane transplantation and a bandage contact lens. This patient again healed with scarring. I will conclude by saying that HSV can often be a masquerade and can present as an underlying etiology of a peripheral ulcerative keratitis. It can be a diagnostic dilemma and must be kept in mind and treated accordingly. I am very thankful to my department at Shore of Charity Eye Hospital for mentoring and helping me out with these cases. Thank you.
Thank you, Dr. Manvi, for that wonderful case series. And now I would like to invite Dr. Mamta Agarwal for her comments on the presentation of HSV due to the tofacitinib.
Thanks, Soham. It's just the same. It's a simple case where we know that we saw some bilateral stromal infiltrates with vascularization, and when the patient was immunosuppressed. So as I treat uveitis, and we do deal with patients where even triple immunosuppression we've done. So we always talk about that herpes is always a risk factor when there is immunosuppression. So it is seen with other drugs also, azathioprine, cyclophosphamide, but the mechanism is different because there we are talking only about immunosuppression. But this is a recent drug which is now FDA approved for rheumatoid arthritis and other diseases. But it needs to be sensitized that it has a propensity for activating herpes zoster. And even the trials, the drug trials, phase 1, 2, 3, they've all shown that there was herpes zoster. The ocular lesions were seen in, I think, 6+2. The 8 cases have been reported. And they also found that it was more in the patients who were from Asia than from the Western world. But again, it was not a significant finding. But just that we need to know that patients who were treated with tofacitinib 5 milligram twice a day, and even 10 milligrams twice a day, they had these lesions which can present as herpes zoster ophthalmicus. Fortunately, we had just these bilateral regions, and I saw it very frequently, very early in the disease, because she was an ophthalmologist actually, and she could sensitize it, and she saw these white spots herself. And then I saw the patient, and it just disappeared, and now she's on antivirals. So it's an easy thing to treat, and it's a preventable. But the question still arises that we're not able to know that, do we really give a prophylaxis of antivirals in patients who are on tofacitinib? It is still a question. And the rheumatologists are still looking at it, that we don't prophylax these patients, but any patient with rheumatoid arthritis or immune-related diseases, they have a propensity for viral reactivation.
Thank you, ma'am. And anyone in the panel, would you like to add some more comments or observations or clinical pearls for these 2 cases?
Could I say something about the second case, Soham?
Yes, madam. Please.
Yes, Dr. Radhika, please.
Yeah, so basically peripheral ulceration due to HSV is a very less known and less diagnosed entity. So in my mind, not that it's backed up by literature or anything, because there's very scant literature available on the subject itself. This comes in 2 varieties. The first is the often missed entity and rare entity of blepharokeratoconjunctivitis caused by HSV. In these entities, the patient presents with lid findings also. In our hurry to look at the slit lamp, sometimes we may miss that there are vesicles on the lid, or the lid is more involved, the lid is inflamed, along with which you have a peripheral corneal disease. This is primary HSV disease. This should not be mistaken for an immune problem or a staph marginal, because why? For a primary immune problem, your first treatment is steroid, and here the first treatment is antiviral. If you did use steroid primarily, you're going to worsen the condition. It is rare. It is more common in younger individuals. But if we see herpetic BKC, then we should pump the patient with antiviral rather than steroid. Second is the variety which the patient, similar to the patients presented in that particular series, where it's an adult patient where you don't have any lid involvement, where you have a peripheral gutter similar to PUK. There is probably a component of immune and infective disease secondary to the HSV. And talking of BKC, one more point on the pediatric cases. These patients tend to have a very high grade and severe inflammatory form of the disease. So lids have to be looked for, and systemic or parenteral antiviral treatment is a must if we see this kind of condition in younger patient or children.
One of Foster's paper talked about anterior ciliary vasculitis in HSV, which can present as like a malignant PUK kind of picture. So that also we have to keep in mind. It could be vasculitis, which is causing this peripheral guttering and these things also. So that's why, like in these cases, you may need a systemic therapy rather than only topical.
Can I ask a question here to the panel about the second patient? Yeah, if we see that it presented as a PUK in the patient in the second presentation. So, and thinking that the patient had a history of herpetic keratouveitis, would anyone think of doing a scraping to test whether it is, or a blood workup to rule out collagen diseases, even if we know that the patient had keratouveitis? Would you think about doing a workup also in these cases? What if it was infective, or it was also associated with a Wegener's or rheumatoid arthritis, even if we knew that it was a keratouveitis known case?
Can I have some comments from Dr. Namrata, please?
Yeah, I think it makes sense, Mata. I think very well said that even though it may appear to be infective or may appear to be herpetic, but whenever it is a peripheral ulcerative keratitis case, the entire gamut of that workup of all the cases for immunologic diseases should be done. I remember we published almost 5 or 6 years ago a series of more than 60 cases in British Journal of Ophthalmology of PUK, where we had done all the workup, and then the commonest cause of PUK came out to be microbial keratitis.
Yes.
Even in that series, despite the fact that for all those 60 plus, the immunologic workup was done, immunologic cause was not the cause of primary, especially in our part of the world.
Yes, so that's what I wanted to highlight, that any PUK should not be taken what is most obvious. So as a clinician, we should always have a differential of the presentation rather than just going by the thing that the history showed a herpetic or keratouveitis. You may actually scrape it and to actually see whether it was a PCR proven HSV or it was a fungal, or even a negative scraping is always helpful to put the patient on long-term treatment, be it antivirals or immunosuppressed drugs.
Also, a small factor which can play a role is if we are lucky enough to see the patient early. It's not just an HSV. If we are lucky enough to see the patient in an early disease, in an immune PUK, the infiltration of the stroma will come first. The epithelium will break down after that. That is the pathology. Whereas in an infective PUK, you will have the ulceration first, and then you will get the infiltration. But most of the time, these are referred cases, and we are not able to see them at this earlier stage.
And interestingly, even a herpetic lesion, because if it was a stromal keratitis to begin, that will also have vascularization, and also the immune mediated, what we see in rheumatoid and Wegener's, they will also have the early pictures very similar. So I think the immune workup in this case was very important.
Also from treatment point of view, because you have, I mean, immediately your treatment strategy changes, whether to use steroids or not to use steroids. And I think that makes a lot of difference as far as the outcomes are concerned. So it helps you to even plan that.
Yeah. And I also want to add regarding my first case, we also saw one patient who was on tufasitinib again for a scleritis patient, and she developed a cold sore after 2 months of therapy. So this drug actually needs some importance, that a detailed history is very important in patients who present in any form to this ocular surface clinics, infections, or red eyes.
True. I think we need to sensitize people about JAK inhibitors that, we can come
And it's
across
quite
such
common
kind
now.
of infections, especially the
We are seeing this.
general ophthalmologists and even the rheumatologists. Yeah.
So if you see your
So-
patients with B27, rheumatoid arthritis, even JIA, you would see this
Yeah.
prescription because we have now the generic form and it's very cheap for the patient. It's just twice a day dose. So you would
Yeah.
actually see this quite often in the prescriptions.
Yes. Dr. Soham, do we take the few more cases, few more questions and some questions from the
Some
question
audience
answer,
questions, yes. So
yeah,
the-
because we have very few we have overshooted the time, but still there are few important questions which we should cover.
So one question from the audience is, how relevant is adding vitamin C and doxycycline for corneal thinning, and how effective is it in stopping stromal lysis? So would Dr. Pradhan like to answer it? And then we can have the panelists.
I do find there is a role in certain cases, not the very advanced ones in which there is an impending perforation or the underlying disease is still uncontrolled. But adjuvant therapy, yes, I feel it still has a role.
Any
And
other
also-
views on this? Role of doxy as well.
I don't know how much it works because there are no randomized control studies to say what happens when you don't use it. But I think there is no harm in using it, and we hope that it works. And in that hope, we do give doxycycline. But then I think there is no clear cut. I'm sure it works, but as such, there are no studies to say that we shouldn't give it. So that is that is why people are giving doxycycline and vitamin C.
think
I
they
have a
both are
question for
taken.
Dr. Sorry, please
No,
go
no,
ahead.
they both were taken from our management of chemical injuries to manage the stromal lysis. So no harm in trying if persons can tolerate.
Yes, yes.
And I have a question for Dr. Jovita and Dr. Savitri, madam. So given that we are doing PCR most commonly, is there still role for the older tests like the immunofluorescence and maybe the smear tests which were done prior in terms of better detection?
So GIMSA stain is almost non-specific. So we don't really do that now unless specifically anybody is suspecting chlamydia, but not for viral infections. But IFA, yes, we routinely do because it gives you whether the virus is active. So it's definitely a better clue, and it also helps in giving you the concordance with PCR. So together it helps for better clinical correlation. So IFA, yes, definitely I would advise.
Dr. Jovita, is it also more specific because we are using the particular antibody over there to, identify the virus?
Yes, it is less sensitive, but it is definitely more specific.
So would you recommend doing both of them together?
So in our institute, we do both always, whenever possible.
And what would be the choice of samples to be sent?
For IFA, you do need cells. So corneal scraping, yes. We do not do it for AC-TAP and vitreous. But AC-TAP, sometimes, I think if you do a cytospin and try and get the cells, then probably you would have a small area with cells. But obviously, you need cells for IFA. Without that, it is difficult to do.
And even some comment about the cost, for people who are working in a private practice and they would like to recommend it to their patients, both the things, PCR as well as.
So, at our institute, we charge 1,000 rupees for PCR, and IFA is also, I think, 500. But
that is very, very subsidized
rate. That is LVPA for our in-house patients. Yes, I really don't know private labs, how much they charge. Dr. Savitri, if you can add.
Yeah. Actually, what Jovita said is absolutely right. I wanted to give a perspective to GIMSA stain, which is not done for inclusion bodies, but mainly for multinucleated giant cells.
Yes.
And those who read the literature may wonder why we are not doing GIMSA stain anymore, because earlier our lab has published papers where we have compared the multinucleated giant cells with IFA and PCR. That has been our main publication a couple of years back. Now, the reason it's not that MNGCs are not important to diagnose, but the reason we have almost stopped doing it is the corneal scraping that we get and genes are stained, the quality is not good enough to detect the multinucleated giant cells. And somehow histopathology samples and pathologists are more adept at looking at multinucleated giant cells than microbiologists. So over a period of time, we have stopped doing that, but it remains an important finding, which pathologists definitely look at whenever they look at corneal buttons from HSV patients. And viral infections is really important.
Good. So we have few questions from the audience. Dr. Meena Lakshmipati asks if real-time PCR can detect load in Valsivir versus Acivir, then that would probably answer the question about bioavailability. Any comments on that?
We haven't tested it, but yes, real-time PCR will detect the viral load irrespective of whether it is treated or not, whichever way. So if it is responding to treatment, you have to do sequentially. I think we'll have to take samples and do it. We've not really done that, but it is possible.
And finally, for all the panelists, and I would direct the question to Dr. Basak and Dr. Radhika. So these, like the HSV stromal necrotizing variant, again, a very big masquerade. So any clinical tips on going about how to detecting and when to suspect?
I think Radhika will answer it. Yes.
Madam has some innovative work on this. It's very fascinating.
If you say so, sir.
Yes,
so, basically, the treatment of this masquerading entity has become slightly better after the landmark paper by Dr. Chodosh. I'm a big fan of that paper because it has imparted little clarity to all this, fuzzy nature of the problem itself. So when you have a little bit inflamed eye, when the patient says that the eye has become red recently and it's not because of the scars, when you're looking at the eye and you see circumcorneal congestion, even when you see scars, we elegantly say epithelial disease, stromal disease, endothelial disease, but we know that when it recurs multiple times, scarring, blood vessels coming along into the mix, then you lose the clinical picture as to which layer is involved. So even in scars, if you stain the patient and see, many times the scar gives a poor background, you're not able to see the epithelial involved. The stain will show you the same. And as far as stromal infiltration is concerned, if you see fuzzy infiltrates, cotton ball-like infiltrates, and if you see that keratic precipitates are within the area of the infiltrate, because we know that these go along the nerves. So the KPs are all, circling around the infiltrates rather than scattered like microsporidial stromal keratitis or fungal keratitis. None of this is particular, but these all added together. If you see an inflamed eye, if you see staining, if you see KPs along with fuzzy bordered infiltrates, or if you see ulceration of the epithelium on top of it, then probably we are dealing with stromal necrotic keratitis. One more pointer over here would be to look at the endothelium, because finally when the disease heals, if at all we are going to do surgery, we need to know whether there is endothelial involvement or not to decide on whether layered grafts will work. For this, I find particularly useful both to do slit lamp photography as well as to do an ASOCT. Because on clinical examination, what is not evident, the endothelial involvement may be evident, so that we know later with the disease quietens whether we should, do a layered graft or we should do a full thickness keratoplasty.
Yes, any other? So before, just I add little, thank you, Radhika, for this, that before taking any transplant procedure, so again, you have to look back. So how much you want to give gap between the question phase and then you do the surgery, because we know that notoriously the penetrating keratoplasty has the highest recurrence rate, and other surgery as well that are recurrence rated. So, and I typically followed that if I at all do, I do a lot of endothelial keratoplasty in the form of DSEK or DMEK. I usually typically start oral prednisolone and oral acyclovir, and currently oral valacyclovir at least 5 days before the surgery. Then I continue for another 5 days post-op. Then I go for maintenance dose. Until when? Maybe 1 year, 2 years, and sometimes 1-8 cases for life. So this is, I'm practicing, and still there are recurrences. And I see in endothelial keratoplasty, there are recurrences, and they have also managed with treatment. Same protocol. Sometimes actually, we do not know when to stop. What Mamta was saying, that when to stop acyclovir, especially if you are dealing with one-eyed patient, multiple recurrences, and you are managing surgically, then probably it is for life. And
Do you
once
give intraoperative samples, sir, for
in
these patients? Do you give intraoperative samples for testing for these patients?
yes, now pre-operatively. So initially I did about 30 cases. I used to, if they are like PCR positive, then PCR negative, and then I used to do the surgery. Then some patients doing 80% are doing fine, but 22% they are having recurrence. Then again I test PCR. So I sometimes do not understand that what is that, all RT-PCR, but when to stop. I have at least 5 one-eyed patients. They are continuing for 7, 8, 10 years. One tablet valacyclovir daily. It is not at all costly, and liver function and renal functions are doing, and sometimes do routine complete hemogram and blood sugar. All these things are going on, but many of them are doing fine. If I compare my results in earlier days with PK and acyclovir prophylactic versus this group of patients, so this group of patients are doing fine because these are mostly endotheliitis.
One thing that one study said that if we give this prophylactic treatment for more than 1 year, then there is development of resistance for 1 year. So they strictly followed the rule that you have not to continue for more than 1 year. And they stopped it. And then if there is recurrence, then you have to treat it like that way.
So basically, I asked the same question to James, and when we met, and like I presented this group of patients to one of the forum, and he asked me, I said this thing that I have read your paper, so what is your suggestion? He said that lifelong, probably for some patient, 1 tablet daily for lifelong. And I mean, it is like valacyclovir or acyclovir. In some countries, the cost is huge difference. But here for the patient compliance, I think once a dose valacyclovir is good, like 500 to 1,000 milligram per day, depending upon the body weight. You can give 1.5 tablets also in some patients, 750, depending upon the body weight of the patient. And mostly they are tolerable and nothing happened serious systemic side effect.
I think that makes a lot of sense, sir, because the infection is for life, the shedding of the virus is for life. So I think the prophylaxis, if not for life, has to also be for a very long duration.
Can I have comments from Dr. Namrata? Any protocol being followed at RP Center?
I think we follow very much what Dr. Basak sir has said. Maybe we use valcyclovir much less than acyclovir, but otherwise it remains essentially the same. There is no difference between what's.
And I guess for one-eyed patients world over, people continue it for a very long time, more or less lifelong kind of a thing, unless there are systemic side effects.
So one word of caution here, I had a patient with Parkinsonism and he was on valacyclovir. And the attendant was very clear that he was disoriented. So I went back to the literature. There are reports. A patient with CNS disease or Parkinsonism, elderly patient who present with zoster, this needs to be cautious, and patient need to be told that there can be a side effect of that. He got disoriented and we had to send to the neurologist and they adjusted the dose. Similar thing in patients who are on chronic kidney disease, diabetics, and dialysis.
Naturally.
And also we send the patient to a nephrologist to adjust the dose. It's not it is contraindicated, but they adjust according to their creatinine clearance and urea level. And so it's a word of caution that you need to know when you're starting this valacyclovir. We are quite comfortable with it, but a patient with kidney disease and CNS disease, it has to be marked important. So it's an important, which I also learned because I saw this patient and he was just disoriented. And we went back and it was written. So So just to be cautious on these
I
two.
have read another paper that first report on Dimectriple in HSV endothelitis published in JCRS long time back, maybe in 15, 16. And they have recommended that, okay, oral acyclovir plus ganciclovir gel once time daily for life.
I also use that, sir. That's what I'm
For
saying.
life, that is the thing. Once daily, not thrice. You told about thrice
I
daily.
use thrice, sir. I don't know because this is not
But once
tested
daily,
anywhere.
I do not know, but
Yes.
I never tried, but
I
nothing wrong,
use
I think.
very commonly in all the grafts, DALC and PKs, what I've done. After a year, I start to sensitize the patient because I'll know the compliance with oral made drop. So I
Yes.
give them Gansey gel, and I don't know what is helping, but I just sensitize them that we have to use this gel, which is quite easy. So they
Easy.
use it, so at least that doesn't drop. So I use it quite, and also thinking that maybe there is a resistance component, maybe this helps. I have no data to say that, but I use it Gansey gel all patients now on the maintenance phase.
I was about to tell that, sir, because even uveitis, uvea specialists, even CMV uveitis also, if the patient can't afford ganciclovir oral, they say equally the topical ganciclovir also will give good effect, and they are for prophylaxis or something, they are giving for a long time.
We do not have the drops. Singapore people have 2% ganciclovir drops. So they treat all herpetic keratouveitis who are CMV related with drops. But because we have Gansey gel and it has good penetration, so I use it quite often in both uveitis and keratitis patients.
Actually, ganciclovir gel is supposed to be a very bioavailable drug as compared to topical acyclovir. So it's
Yes.
not only about the toxicity. For so much of toxicity, I've never seen too much of acyclovir toxicity topically. But it's supposed to be an extremely bioavailable drug to use, ganciclovir gel. And on the topic of treatment for post-graft situations, we must remember that if it comes too early, it's not a recurrence. The corneal nerve has to grow back into the cornea. So it takes about a few weeks at least, then only you can have a recurrence. Otherwise, it's simple pseudodendrite because of epithelial healing problems. Sometimes, many times in a new case, we don't see an epithelial dendrite and a stromal involvement happening together. That's very rare. Whereas in a graft, it's the reverse. The moment you get a dendrite, zoop, it kind of spreads very rapidly and starts involving the stroma also. So epithelial and stromal involvement concurrently is very common when it happens in a recurrence in a corneal graft.
And when you're talking about the graft, I recently have seen a couple of patients where it has come as a graft rejection. But we need to know that there are some clinical features in a grafted eye which can suggest that it's not a graft rejection, but it is a viral activation, which sometimes the surgeon may not be aware that patient had a history of this. So what we need to know the pigment clumps, and again, what we know how to differentiate between graft rejection and a viral activation. So I think this is a very important differential. We keep treating them with only steroids, but what if it's a viral? So AC tap in these cases can clinch the diagnosis. So we need to know that viral and this graft rejection can mimic each other very closely.
We need to look at the host very carefully. If you see pigmentation or KPs in the host, then it is not a rejection. Then it is some kind of a infection which is recurring, because rejection will never happen in the host itself.
Yeah, but the borders are very opaque most of the time when we have grafts. So the peripheral cornea may not be seen as clear to see whether there are KPs. So most of the time the KPs are on the central clear cornea with corneal edema. So that
if you see, it helps. If you don't see, then it's not diagnostic. But if you see, then it contributes.
So that feature is more theoretical. I think that we see KPs on the host side. Most of the time, these are grafted eyes. So the central cornea, but we need to have this differential.
So main problem happens, just one comment on this.
Sure.
Main problem happens that it is not PK or DALC. If it is an DMAC procedure,
the problem.
you cannot differentiate that which is host and which is the donor.
Yeah.
There the problem of identification of rejection and versus recurrence. And in fact, there are few published paper with the DISSEC series with ultra thin DISSEC that they are thinking of it is rejection, then they have taken it out, they have sent for histopathology and then PCR, and it proved to be.
I think that was Donald Tan's report, sir, from Singapore.
And also Price Group also reported initially 4-5 cases and ophthalmology, and those are very interesting. I mean, these are very
I think
With endothelial keratoplast, it is a very gray zone actually.
yes, very true. You shared a case on social media long back, Dr. Basak,
Yes, yes,
about the
yes.
same thing, and we all learned about that at that point of time. I have to do a difficult job. I wouldn't like to, end this session the way it is going on. But as there is an end to every good, thing, we also have to, because we have exceeded time much more than what usually we, keep. So it is quite, past the discussions. So I would like to wrap up the sessions. And at the outset, I would like to thank everyone, especially the participants who have been patient so far and have been throwing questions into the Q&A box. I would also like to thank our presenters, Aditya, Nibedita, Manvi, Gayatri, Dr. Mona, and Dr. Charuta for bringing in such wonderful cases. And it was so interesting that we had an array of cases which covered almost the whole spectrum today. And apart from that, we had presentations from across the country. Like, we had from North, we had from South, and representation from, Eastern part. So that was a very unique part of this session. And also, I would like to thank our esteemed panelists. Otherwise, without them, this would not have been so interesting. All the panelists, our CSI panel, and again, last but not the least, our CSI back office people who have been working very hard to make sure that this runs almost seamlessly. Thank you so much for being here, and we see you for, next KeraCon at Chandigarh, as well as, whichever are the next, live sessions from CSI. Thank you so much. Good night, everyone.
Thank you,
Thank
Thank
you.
you.
Very much.
Can just stay there for a moment, and maybe Shabina can take quick pictures, and that will be shared with everyone.
Thank
Stay
you.
there. Everybody should be,
Thanks, Paras, and thanks, Soham, for coordinating the whole thing.
Thank you, madam.
I didn't thank Soham because he had done the groundwork. So much of that I was totally relaxed running the whole thing.
And I must thank Paras madam as
I
well.
think he didn't spare a single piece of literature on the subject.
Absolutely. Absolutely. Yeah. So I think we are done. Shabina has given an indication, and good night, everyone, and see you next time.
Okay. Good night.
Thank you.
Thank you, everyone.
Good night.
Good night.